Welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Alan Sardana, and with me as always is SeamlessMD's CEO, Dr. Joshua Liu. Today we're joined by our very special guest, Dr. Rebecca Mishuris. Dr. Mishuris is a CMIO at Mass General Brigham. She's also a practicing primary care physician at Brigham and Women's Hospital. Dr. Mishuris, Rebecca, welcome to the show.
Thanks very much for having me.
It is so awesome to have you on the show today. Your path to becoming CMIO is very different than most of the CMIOs that we've had on the show before, in that you were into technology before getting into medicine. And so I'm really curious to start the conversation there. Like, where did this passion for technology come from?
It's a great question. And actually, I first want to challenge that I'm amazed that any of us have the same path, because at least in the current generation of CMIOs, there was no path, right? We really had to chart it ourselves. Now there's much more of a path with informatics fellowships and things like that. And so I'm amazed that there's any sort of consistency at all between us. But I would say my own path probably is a product of my genetics and the time that I grew up in. And so I grew up around technology. Gadgets were very cool in my house. My father was in technology. And so that was just part and parcel of my life. And then I was in college during the dot-com bubble. And so that was certainly kind of an area of interest of mine and many of my peers as well at the time. I was not super interested in the kind of volatile world of startups, which maybe was a good thing when the dot-com bubble burst, but really went into the technology side from a strategy and implementation consulting perspective. That was really how I got into it in the first place.
Yeah. Amazing. And then somewhere down the road, I mean, you were a consultant in that field for maybe a couple of years, and then something pushed you towards medicine, and in particular, internal medicine. So I'm curious, what was that?
So a lot of the consulting I was doing was actually with what I'll call public sector systems or public sector entities. So everything from Department of Education to higher education universities to government. And the government entities I was consulting with were in public health. And so it was everything from hospitals to, local departments of public health. And I think through that, really realized that I wanted to be the doctor on the other side of the table, really having the impact on the ground with the patients, using the technology, but really much closer to actual patient care. So I worked in consulting for a few years, went back to school, and went into medicine. My evolution to internal medicine was not straightforward either. There was one point I was going to be a neurosurgeon, and then I was going to be a pulmonary critical care doctor. This was during medical school when you're just trying to figure out who you want to be, right? And then really came to internal medicine because I really was taken to this idea of taking care of the whole person and doing it longitudinally. Yeah. So not just taking care of the whole person when they're super sick in the intensive care unit, but taking care of the person over the course of their lifetime. Not quite the course of their lifetime. I'm not a family medicine doc. I don't take care of kids, but at least longitudinally over the course of someone's adulthood.
That's awesome. And so I'm curious now, looking back, it's a two-part question. One, would you do that same path again, or would you recommend that to others? And then part two of the question is, how do you believe that the combination of coming from a tech first kind of background and then merging it with medicine, how do you think that's influenced your approach moving forward with healthcare tech?
Mostly I recommend to people to do what they want to do, to what intrigues them and what excites them. For me, it made a lot of sense to do it that way. I think once I then got to medical school, I was no longer 22 and right out of college. And so I had a much clearer idea of what I wanted to do in medicine and how I wanted to impact the field of medicine, and also a much better idea of how I could use technology to do that, as opposed to coming in straight out of college with maybe not so much experience, real world or otherwise, and trying to figure it out from there. So I think there was definitely an advantage to coming into medical school, having lived in the world for a while and taken that approach. I think also, right, having seen how technology could actually impact clinical care before I was in clinical care meant that once I got there, I was able to really have some insights into how the technology works and then draw it even further into the clinical realm, really understanding at that point right? Where were the pain points in clinical care delivery? What were the challenges we had? And how could the technology come and sit in that space and try and solve some of those problems?
Yeah, I think it's so fascinating. I think a lot of people that I've met who've started medicine later on in their careers, they enter their training with a lot more intention about the type of care they want to do, or maybe at least the life that they want to lead and their purpose and all that. And it's interesting because you may end up picking a totally different specialty than you would if you had just gone straight into the medical school after undergrad. It's fascinating.
Today's episode is brought to you by DeepScribe, AI clinical documentation that physicians and health systems love, documenting specialty and complex care with ease and precision. Josh, have you heard all the buzz around ambient AI and virtual scribes?
Definitely. Clinicians are spending hours a day on documentation, so improving their day-to-day and reducing burnout is huge right now. You know, you and I have seen quite a few product demos for ambient this year, but I have to say, DeepScribe was one of the most impressive.
Well, Josh, you trained as a clinician. What stood out to you most about DeepScribe?
Well, using AI to transcribe and summarize the clinician-patient conversation is honestly table stakes right now. But a big challenge for CMIOs and CIOs is driving actual clinician adoption. So what really impressed me about DeepScribe is how well it can be customized to different specialties and workflows with dozens of templates as starting points. You know, that would be critical to me as a clinician because I just don't have time to build templates from scratch.
So true. For me, I was particularly impressed by the auditable notes. You can highlight any part of a note, and then DeepScribe shows you exactly where in the transcript the note was generated from. So you can find that evidence right away. That builds trust.
Oh, exactly. You know, being able to confirm that something wasn't hallucinated is so important for clinician trust and safety.
Yeah, that same attention to detail that led to really high clinician adoption is also resulting with clinicians saving up to 75% of documentation time.
Wow, that's incredible. But how is DeepScribe's accuracy with specialty care or complex cases?
That's the best part. DeepScribe's proprietary LLM, Heal AI, is trained on over 3 million patient conversations. It's then further tuned by specialty and subspecialty cases, making it way more accurate than GPT-4-based solutions. Pair that accuracy with DeepScribe's customization studio to personalize the experience for different clinician preferences and workflows, and it becomes incredibly flexible.
You know, Alan, speaking of flexibility, I could use some yoga myself. Flexibility is key when it comes to working with health systems with so many moving parts. DeepScribe sounds fantastic. Where can health systems learn more?
About your yoga? I don't think they want to. But about DeepScribe, check out deepscribe.ai. That's deepscribe.ai to learn more.
So, Dr. Mishuris, you know, it's a digital health podcast, so we have to get into the buzzwords a little bit. AI is a very hot topic right now among digital health leaders, but there's so many different use cases that you could tackle. It's endless. Curious your thoughts on what you believe is the low-hanging, highest ROI use case in AI for health systems right now, and what use cases do you think maybe are a little bit overhyped in healthcare right now?
There's probably a bit of hype to all of it, but I think, clearly there is a mechanism for particularly generative AI to start helping us in the kind of administrative burden space. That whether that's the clinician writing a note in clinic or a revenue cycle, folks on the back end looking at the billing and trying to make sure that the documentation fits with the billing, or even just trying to reconcile billing that happens on the back end. So I think there's clearly a space there that is pretty real today, right? Where the technology can really meet the challenge that we have. And I think that there's definitely a lot of hype even in that. But that feels very tangible to me today, where you could actually go out, find a company or build a system that could actually address those challenges. So that gets at kind of potentially at burden and burnout, right? And a lot of the potentially workforce challenges that we're facing in healthcare today. Again, not just clinical workforce challenges, but across the spectrum of healthcare delivery.
For sure. So Dr. Mishuris, I've actually also heard in a previous podcast, you were talking about generative AI for patient portal messages, maybe drafting some of those. But I think you have a really unique perspective in this area. So I'm curious to get your thought process on guardrails for some of these generative AI initiatives, just to, make sure that it's not taking away from the patient-provider relationship and it's not just fully, out of the provider's hands. What are your thoughts there?
Yeah, and this gets a little bit to trying to temper the hype, I would say, and being really purposeful in our evaluation of these tools in how they have an impact on care delivery. And so I think it first has to start with, what are we trying to achieve, right? If you're trying to achieve a decrease in provider burnout, you're going to look at one set of tools and one set of outcomes. If you're trying to achieve a hard ROI around coding, you're going to look at a different set of tools and a different set of outcomes. And so, those are things where, again, probably pretty close to reality today. If you're trying to make sure that everyone is adhering to evidence-based medicine all the time and actually, decrease mortality, either inpatient or outpatient, first, there's a lot of hype around that right now. I don't know that the technology is actually where we need it to be to fully try and address that space. But again, you're going to look at a different set of tools and a different set of outcomes. And so taking a robust approach to the evaluation of the impact of the tools is where I start from, because these are just tools. They're just technology tools, right? They're another tool in my toolbox to try and address the challenges of healthcare. And so the same way that I would address what I'll call a static technology, right? Doesn't change over time. It isn't subject to drift, isn't subject to hallucination. I want to know, is it working? Is it having the impact that we intended it to have? Is it addressing the challenge that we need addressed? And so if you start with that, right, you've then automatically put up your guardrails, because you want to make sure that it's having that impact and not some other impact, right? Unintended consequence of the technology. And so as we look at things like using generative AI to draft responses to patient portal messages, we're looking at, is that decreasing the burden on the people who are drafting those messages and reviewing them? But what is it doing to the patient experience, right? How does the patient perceive those messages? And do the messages actually help further their care, or do they actually just engender more questions? And so it's looking at both sides and making sure that you're looking at, again, kind of what you're trying to impact, and then also for any unintended consequences. I think importantly, right, thinking about how do we responsibly use this technology? Again, same way you would think about any other technology, I think it's coming to light more in the generative AI space, because at some point it's a bit of a black box, right? Because at some point it actually does experience, we do see drift in models, we do see hallucination. It's not perfect, right? To some extent, we're trying to scale and robustly implement an innovative technology. We don't do that with most innovative technologies, right? Most innovative technologies, we go slow, we go carefully, you might take an act fast, fail fast, right, kind of approach, but you're not looking to scale it across hundreds of thousands of providers tomorrow. We're trying to do that with some of these technologies. And I think, taking this careful approach to evaluation will slow us down a bit, but make sure that we're not seeing those unintended consequences.
You had a really good point about, even if, let's say, we're using generative to draft patient portal messages for clinicians, and maybe we measure improved well-being, maybe we measure time savings for the clinicians, but then there's the counterbalancing measures of how has it impacted the patient experience, and has it actually improved their care and moved the ball forward for them? That's a great point. I'm kind of curious what you think might be the best ways to measure those counterbalancing metrics. So, for example, like, should health systems be measuring, and maybe they already are doing this, like measuring satisfaction with patient portal responses and seeing that's changed, or what's the best way to help understand that we're not losing out on the patient-centered metrics as well?
Yeah. I think you don't have to reinvent the wheel, right? We generally know how to evaluate patient experience. You use the same tools, you use the same questions. It's just targeted at a different aspect of their care now. And so actually people are looking at the AI-generated portal messages and how patients perceive them. One study actually showed that patients thought they were more empathetic than the human, which you could imagine, right? Somebody who's burned out, who's responding to their 100th portal message that day, right, is going to maybe be a little bit less empathetic than the computer that is told to always be empathetic, never going to get tired, never going to get burned out. And so I don't think we have to reinvent the wheel in evaluating patient experience. And I think it's absolutely imperative that we do measure patient experience with the tools that are patient facing. The same way that if we were trying to implement a tool to impact clinical decision-making, we would want to make sure that those are safe and producing the same or higher quality of care outcomes than the human alone.
One of the things that we know is that for a lot of tools, it's not one size fits all. And so, for example, when it comes to generative, there was a study recently from Stanford where they looked at using AI to draft the patient portal messages, and they saw differences in both the usage and satisfaction between different types of frontline clinicians. So, for example, in primary care, the pharmacists loved using it way more than the primary care nursing staff. I'm curious so far for some of your generative initiatives, have you learned anything in terms of, hey, these tools have been really well received by certain specialties or clinician types, but not so much in others, and any insights as to why you're seeing some variability in uptake?
Yeah. So I read the same study, and the variability was really interesting. And to me, it meant that we need to, again, kind of be careful about how we're implementing them, and that they aren't going to work for everybody, right? And not only by specialty, right? Like they're not going to work for every provider type or every clinical domain. And that's part of the work of understanding these innovative technologies is where are they working, right? I keep talking about, I want to understand what's the phenotype of the provider that is really going to benefit from ambient documentation so that I can then really understand what that provider type is and provide them support with starting to use those technologies, because we know on the back end, it will be that much more impactful for them than for your average provider. What we've learned so far is that there's probably some sort of curve. I don't know if it's a bell curve or a sine wave or what, but some sort of curve related to burnout, where there's a threshold of burnout where you're so burned out, it's not clear that any one intervention will help you. But then there's somewhere along that curve of burnout that it's clear that ambient documentation is going to help. But that has to be paired with why you're burned out, right? And burnout is so multifactorial. But if you have someone who is burning out or kind of early in their burnout stages, where some portion of their burnout is related to documentation burden, this is clearly going to be a huge win for them. It's not a panacea. It's not going to completely erase all of the other things that are contributing to their burnout, but it's going to give them some space to breathe. Where, I've had providers who've used these technologies now for just 2 days saying they're no longer quitting medicine, right? I'm willing to just put that on a slide, right, as my ROI analysis. So there's clearly evidence that, kind of anecdotal at this point, but about to be data in a few weeks here, that these technologies are going to work for some people. I think the other space has to do with the type of clinical care you're delivering and the extent to which the large language models have been trained on that kind of clinical care. So I can't actually tell you which specialties yet because we haven't run the data yet, but just from anecdote, right, it's clear that there are some specialties where the large language models are just better tuned to the type of clinical encounters that those specialties might have and are better able to summarize the visit and create an assessment and plan than some other specialties where, I suspect that just the large language model didn't have enough data to train on. And as time goes on, as more and more people start to use it and the data balloons, it will actually get better, right, as we train the models more. But right out of the gate, I think we are going to see some of this differential. But again, even in those specialties, if you have someone who's burning out, where a lot of their burnout is related to documentation burden, it still might be helpful, right? It still might be better than nothing. And so again, that's what we're trying to figure out and tease out from the pilots we're doing.
And sorry, can I ask you, so with Ambient and Scribe specifically, it's exploded in terms of the number of solutions and companies that have sprung up, especially in the last year or so. And so for other health systems who haven't, done this yet, who haven't gone through an evaluation yet, how do you think about criteria around picking the right kind of technology for a health system? Because on the outside, someone who's not in that space, it looks increasingly commoditized, but there's got to be some specific dimensions that you find to matter most. So what would you advise another health system leader trying to figure out how to best evaluate the options out there?
Yeah, it's a great question. And again, I'm not sure that it's all that different from evaluating any technology, right? And so you gather your clinical or operational requirements and you gather your technical requirements and you go out and you see who meets your requirements. And you're going to have things that are must-haves like privacy and security. And you're going to have things that are really, really nice to haves, maybe like integration with your EHR workflow or availability on certain other platforms, certain, mobile device platforms. But it really has to do with your system's needs, and which may differ, pretty drastically between for instance, a community health center in the suburbs somewhere versus a large academic medical center in the middle of a city, right? Their needs are going to be drastically different. So what they're looking for is going to be different. You're absolutely right, though, that this market is exploding, which is what we see in these kind of immature, innovative marketplaces, right? Where you see a ton of companies coming out all at once. And then over time, we will see that rationalize to probably, maybe a handful of vendors in this space that have differentiated themselves for different reasons, right? Someone's going to integrate really well with a certain EHR or another EHR. Maybe there are a couple that are specialty specific, where maybe there are a couple of specialties that just, general large language models are not good enough for. And so we see a couple in specific specialties come out. We're going to see probably different price points, different backers, different funding mechanisms, things like that. But for now, I wouldn't approach it any differently than you approach evaluating other technology vendors. I think that there are a couple of things that are, again, specific to generative AI, which is what was the training data, right? What models underlie the actual generative AI product? What's their monitoring look like to make sure that they're not seeing a ton of hallucination, that the model's not drifting too far afield? And what is their privacy and security controls? And the only reason I say that's different than maybe some other technology you would look at is because of the vast amounts of data that get generated from ambient technologies, from generative AI technologies in general. And so I think we are always looking for the highest security and privacy of our patients' data and our own data. But I think that becomes even more important as we talk about the exponential amount of data that's required for generative AI systems.
In a sense, it's important for these leaders to have clarity on what are objectives, what are our must-haves, nice-to-haves, and so forth, and tailor accordingly. It makes a ton of sense.
Yeah.
So Rebecca, you brought up the idea of clinician burnout and it being multifactorial. And I think that is so true. I've heard you previously share that you believe EHRs are often the face of burnout, but maybe not the root cause. And so I'm curious, at what point do you look at technology solving these issues versus a non-tech solution? What are your thoughts on addressing more of the root cause of burnout?
Yeah, I think importantly, as you mentioned, right, there is no single root cause of burnout. It is multifactorial for basically everybody. Usually there's maybe one or two drivers that are more important than others in causing someone's burnout. But overall, it's a multifactorial challenge that we're facing. And yes, I have been known to say that EHRs are the face of many of the drivers of burnout. So if you ask a clinician just in conversation, what's the cause of their burnout, they might say the EHR. But if you dig down, you'll realize it's a regulation that's requiring them to do something in the EHR. It's the fact that they just lost a medical assistant who used to do X, and now the provider has to do it, right? So it's not necessarily the technology itself, it's what that technology is representing. To that end, we can actually use technology to try and solve some burnout, but I don't ever think that technology alone is going to be able to do that. The same way that the drivers of burnout are multifactorial, the solutions also have to be multifactorial. And so in the same way that we think about people, process, and technology, I think we have to think about kind of the clinical space, the operational space, and the technology space, the technology solutions, and bring all three of those to the table to really try and start tackling the burgeoning problem that is burnout. And so again, it's never just going to be technology, right? It has to be technology with the clinical and operational processes around it, and the people, quite honestly, as well. But I obviously believe in the technology. So,
well, I mean, you have to in your role.
Yeah. I mean, it's good. It's good to have some amount of skepticism, right, and questioning. But I think there is absolutely a role for technology in trying to address burnout. But I think we also have to be careful, right? It's a double-edged sword. Technology has clearly also caused some burnout, so we need to be careful that we're not kind of falling victim to that either.
Today's episode is brought to you by SeamlessMD, which enables health systems to digitize patient care journeys, leading to lower lengths of stay, readmissions, and costs. Josh, you used to be a doctor. Did you ever feel like patients showed up unprepared for surgery? Or maybe you felt like you were sending patients into a black hole after discharge?
All the time. We give patients paper and verbal instructions, which are so easy to forget and really hard to follow. And we have no idea what happens to them outside the hospital. So what happens? Well, because we worry about them, we keep patients in hospital longer, but that drives up length of stay and lowers throughput. Plus, after they leave, patients get readmitted for infections and all kinds of problems that we could have just caught earlier if we monitored patients.
What if I told you there was a way to give every patient a virtual companion so you could automatically engage and monitor them through a surgery, a cancer journey, or a chronic care journey, and drop the length of stay, increase throughput, and lower readmissions?
Gosh, Alan, that would be amazing.
So that is exactly what SeamlessMD does. It allows health systems to engage patients on their own phone, tablet, or computer with automated reminders, education, and symptom monitoring. Basically a GPS through any healthcare journey.
That sounds fantastic, but does it actually work?
It does. Health systems have done over 40 studies and evaluations showing how they use the solution to reduce length of stay by 1 to 2 days, readmissions by up to 89%, and costs by over $1,000 per patient.
But how does that work with my EHR?
That's the best part. SeamlessMD is the only solution in this space with direct integration partnerships with Epic and MyChart, Oracle Cerner, and Meditech.
Well, I am getting a colonoscopy soon, so I really need something like this. Where can my health system learn more?
Well, Josh, thanks for letting me know. Your health is very important, and endoscopy is just one out of the 50+ out-of-the-box care plans available today on SeamlessMD. Go to www.seamless.md. That's www.seamless.md to learn more.
Do you ever worry that generative AI may prevent some of our up and coming trainees from having the full education as a clinician? I'll give a good example. So someone like yourself who's been practicing medicine for a while, you know how to write notes. You've written thousands of notes. You've documented all kinds of things. And so for you, adding in generative to take some of that administrative work away to summarize, you haven't really lost any clinical skills. But for folks who've never written a note, never had to organize their thoughts into a concise, assessment and plan and write it down, and now they can just go straight to, I've done the encounter, a model has been highly trained, it'll summarize the note. In fact, at some point, it's going to recommend the assessment and plan for me. That's best practice. I don't have to really think for myself. For you, that's fine because you've done that thinking decades before. I'm a new trainee. I haven't had to really do it yet. Oh, I don't have to anymore. Might that be a bad thing?
It could be a very bad thing if people approach it that way. Absolutely. Because I don't think it's that they don't have to think anymore. I think it's that we have to train in different ways so that people think differently, right? Because we will, at some point, right, have that decision support that will help us formulate a differential diagnosis and make sure you don't miss the rare zebra, right? Which people miss because they're rare, right? And help you in making sure that you're practicing evidence-based medicine. The evidence changes dramatically all the time. And there's no way that any single human would have all of that knowledge in their head. And so it's going to be able to help us be better doctors. But I think that's the key. Help us be better doctors, right? Not replace us. And so there has to be a shift in how we train medical students and residents to do that thinking, to do that critical clinical thinking without having to write the note. So you're absolutely right. When I trained, I was trained to write down the HPI, write down the physical exam, write down all the hard, data evidence, and then synthesize it as I was writing my assessment and plan. And that's how I have always practiced. I'm no longer doing that synthesis as I'm writing my assessment and plan because it's being drafted for me. And I don't want to wait actually until that draft comes back because I know I will be subject to bias, right?
Yeah.
That this is already written for me. So I'm going to forget about something that maybe I would have brought to the forefront had I not seen it written already. And so I'm now doing that kind of critical thinking in the room with the patient, actually, where I'm talking about, these are the 3 things that could be going on. I think it's most likely to be X, and here's what we're going to do first. That may scare some patients because it becomes clear that medicine is still part art in addition to science. But for other patients, I think it's actually making them feel more involved in their care. And for me, it's allowing me to continue to do that critical clinical thinking without doing it as I'm writing my note. Now, again, that means that we're going to have to train students differently. Now, maybe we still train them to write their own note first so that they learn how to do that critical thinking, but then we train them how to be essentially data analyzers or navigate the note that is drafted to add in their clinical acumen on top of that.
How far do you think or how soon, this is probably inevitable, do you think we can bring generative closer to, let's say, the inpatient environment? So maybe you're doing this already, but I haven't yet seen anyone talk about, hey, I'm rounding on patients, at 6 a.m. and ambient is listening in, so I don't have to write every, note down. Is that happening anywhere yet? Do you know?
Yeah. We are actually using generative AI for ambient documentation across all care contexts: emergency room, urgent care, inpatient, certainly ambulatory. So we are doing that work. Again, not clear if it'll pan out yet in that inpatient space. There have definitely been some people who have said that it's helpful for an initial admission, maybe less helpful during daily rounds, but that may also be how we're trying to use it, right? We're trying to use this product that was really initially developed. And when I say initially developed, it was like a year ago, right? Like we're not talking a long time ago, but initially developed for the ambulatory space, and we're trying to fit it into the inpatient space. And so maybe the inpatient ambient documentation, maybe the technology needs to be a little bit different. Maybe the process needs to be a little bit different. And so I think we're still very much in the early stages of working through that, but I absolutely think it will be in the inpatient space. It just may look different than how we are using it in ambulatory, where, I take my phone out, I ask the patient if I can use this technology, and I, turn it on basically, and I just kind of let the phone sit on the desk. And then at the end of the visit, I stop it and my notes in the EHR. It may be a very different process that we need to use to be able to take full advantage of the inpatient space.
I mean, probably the future, you have microphones built into the room. I mean, obviously, like patient consent and you can turn it on or off or all that, but I'm guessing at some point you won't have to take your phone out.
Yes. Yeah. No, I mean, at some point I won't have to take my phone out. At some point, right, it'll know when the visit's over. I won't actually have to hit stop recording. But, again, what's the comparison? The comparison is my writing my note myself. So taking my phone out and hitting start and stop, not a big deal.
Yes, absolutely. It's still a big leap forward.
Yeah.
Rebecca, I had a question for you around teaching and, instructing the next generation of healthcare professionals. I've heard you mention in the past how one of the main reasons why you love medicine is because teaching is at its core, and we're all teachers in the field. And so I'm curious, how does this passion translate to how you approach that next generation, and why is it important for you to maintain a certain sense of what you've learned and passed on to the next generation, and especially as now we integrate some of these new technologies into our practice and new workflows and everything?
Yeah. So I do. I think it's incredibly important that we teach in medicine, right? It's how we all learned, and it's how the next generation will learn. If we don't pass down our knowledge, we just repeat the mistakes of the past. That's kind of like generally true in life, right? And so, to some extent, I purposely work in academic medicine where there is an environment of an imperative around teaching. I don't tend to say that I teach in the traditional sense of the word, meaning I don't stand in front of a class and teach them every day or every week. I teach hundreds of thousands of people every day through the technology that we implement. We certainly teach, thousands and thousands of people every day just through the training to use the technology. But it's really important to me that that's part of the culture. And I think, again, part of my own imperative around these new technologies is that we share what we're learning and that we teach through dissemination of what we're learning, whether that's presenting in a meeting or publishing a paper or going on a podcast, that we're sharing information so that we're not all reinventing the wheel. And that, I obviously genuinely buy into the idea that, two heads are better than one. And, the more we can have people thinking about these challenges, the better we will all be. And so, yes, I think it's incredibly important that we teach in many different ways. And, from a digital technology perspective, change management is a huge part of what we do with any technology. That's teaching, right? Change management is teaching, whether you're teaching someone where to push, right? Like which button to push, or even more importantly, how to incorporate it into their workflow. that is teaching. And I think we need to acknowledge that that is a form of teaching that many of us, all of us in the informatics field are doing today.
Right. Can I ask you, like, what would you say is either maybe the most surprising or the most important thing you've learned teaching clinicians to adopt new technology?
I think the most surprising thing is that there are people who are just total technophobes and totally unwilling to embrace something where I can show them evidence that it will benefit them, and they can't get past the fact that it's technology in any form. That has been surprising to me. Now, maybe surprising to me, maybe because of how I grew up and the fact that technology was always cool in my house and, the environments I've put myself in. But that has been surprising to me, that there are people who just, kind of a priori will reject something because it's technology. But we have to get through that, because quite honestly, those are usually the people who stand to benefit the most. And so, again, figuring out how to make it part of their workflow, how to make the technology to some extent invisible, right, becomes really important with people who are apt to reject technology for being technology.
I think one of the fascinating things is that, and those same people, probably grew up with some types of technologies and they're comfortable with that because they grew up with it. So it's almost like in their minds, they are not comfortable with technology, but they clearly are because they grew up with some of it. It's just the new ones that they're just, there's a barrier there.
Yeah, they're not comfortable with change is really what it is.
Right, yeah.
And I think to some extent, we're all uncomfortable with change. That's why there's like a whole discipline around change management. But I think there are some people who are more apt to embrace it than others.
Right.
That's not surprising, right? That there are going to be people who take to it more readily than others. That's not surprising at all. But the fact that there are people who just would say, no, not for me, without even seeing it.
Well, what do you found to be the best way to convince the skeptics? Is it more about close peers that they respect getting benefit? Is it evidence and data? Like, what tends to sway people the most who are skeptical?
Yeah. So when I was earlier in my career, I thought it was data, right? To say like, you practice evidence-based medicine. This is evidence-based technology, right? Like it works. Here's the data to show it's not data. It's their friend. It's their colleague telling them that it worked for them. And so, that is part of change management generally, right? Finding out who are your stakeholders, who are your champions, and making sure that those people are going out into the world and being those champions. But it really does end up being that personal connection that people trust the most. Again, makes sense, right? We're human. We thrive on personal connection just as humans. So this is no different.
Right. It's funny because I'm going to go into a consumer thing, so this is different than healthcare. But if you look at any major like consumer products out there, there's not much data, but people look at Amazon reviews, Google reviews. Like that's how I make assessments on some of these products. What other people think? It's so fascinating.
Yeah.
Is actually just double clicking on the idea of finding your champions. I'm curious, are you actively always looking for champions within your organization? Are you looking to those who just raise their hand and they're saying they want to pilot something new? Or how do you find those champions that can really ripple across and convince some of the skeptics that you might have?
Yeah, I am always on the lookout, right? So anyone that I meet, I kind of, you're talking to them, you're figuring out who they are, you're figuring out what they do, what they're interested in, and you can make an assessment about whether they're, going to be helpful in helping their peers take on some new, whether it's a technology or a new process, whatever, to be helpful in that space. So yes, always looking. I think oftentimes we then specifically look around a specific product or implementation. And, oftentimes it ends up being the leaders in clinical areas or amongst certain roles that become those champions. Oftentimes it's more important that it's not the leader actually, but maybe the leader can help you identify who the real champion can be or should be. And it's not always the person who raises their hand first. Sometimes it's the person who's a little bit reluctant and then uses it and has an amazing experience. That person is like the perfect champion, right? Because they convinced themselves that this was good and helpful and was going to be an improvement. And they're that much more able to then help their colleagues through that process.
Right. They would understand the skepticism to begin with. Yeah.
Your best champions are like the known skeptics in the organization.
because everybody knows they're skeptical, right? And so like, if they're convinced, then maybe I should be too.
Yeah. Great point.
Fair point. So Rebecca, just being mindful of your time, we're going to flip over to the Fast 5 lightning round. So this is 5 questions to get to know you a little bit better. The first question we have is, what is your favorite book or book you've gifted the most?
So I would say my favorite books are John le Carré novels, but I don't gift those because not everybody's going to take to like political thrillers.
Right.
I gift a lot a book called Ask for It, which is about women in leadership and making sure that women are promoted as much as their male colleagues are and how to enact that. So I find that, women often have a lot of mentors, but not a lot of sponsorship, not a lot of promotion. And so I find that to be a good book.
Yeah, awesome. Question 2, who is a person either dead or alive who you'd love to meet?
Oh gosh, I think Dr. Fauci. I just have incredible respect for his career and certainly his leadership over the last few years. So I'd probably do some fangirling if I met him.
Amazing. Question 3, would you rather have super strength, super speed, or the ability to read people's minds?
Oh goodness. I think super strength.
And
super speed seems like we all go too fast to begin with. And I don't know, reading people's minds might be really troubling.
Right. Yeah, fair enough. Question 4, what is something in healthcare you believe that others might find insane?
The fact that I still have a fax machine in my office.
Right. Yeah.
I mean, it's a little crazy, right, to be talking about generative AI. And yet, last week, a patient had to fax me a form that we then had to fax back to them.
Question 5, if you could travel back in time to any event or moment, what would it be and why?
Oh my goodness, so many options. I think in the US, at least, February 2020, before the world shut down.
Oh, wow.
And just enjoy things a little bit longer before the world as we knew it changed.
Yeah. I love that answer. That's great. And there was a little bit of a theme that I've caught throughout the conversation, which is to take time for patience and slow down. And we're living in such a fast-paced world. And it's so funny because you're right at the center of it and you're moving so fast with all these new initiatives. But I love that advice to really take a moment and breathe on it. Thank you so much, Dr. Mishuris, for coming on the show today. That's a wrap for this episode of The Digital Patient, hosted by SeamlessMD. You can follow us on Twitter at SeamlessMD. And if you like the podcast and you want to learn more, visit www.seamless.md. Dr. Mishuris, Rebecca, again, thank you so much for spending some time with us.
Thanks very much for having me.